present us his presentation.
The case that we have seen in our unit. My patient is 37 years old female patient from Alexandria, housewife, married with 2 sons. Our patient started complaining of right shoulder swelling and right hip joint pain since December 2022. Our patient is a known end-stage renal disease patient on maintenance hemodialysis since 2016. 2 years later, she started complaining of right hip joint and right shoulder pain. She started analgesics and anti-inflammatory agents, but without any improvement. Her doctor started for her intra-articular corticosteroids injection, and the pain was improved at that time. In 2020, she developed the same pain again, and some investigations were ordered for this patient. At that time, the intracranial hormone was 1,200 picogram per milliliter, which is high. The serum corrected calcium was 10 milligram per deciliter, which is high. And the serum phosphorus was 4 milligram per deciliter, which is in the upper limit of normal. And the 25-hydroxyvitamin D was 2 milligram per milliliter, which is very insufficient in this patient. The patient was advised to start cholecalciferol and bone monthly for 5 months, and the follow-up impact hormone was 700 picogram per milliliter. At that time, she was advised to start sinacalcet, which is a calcium mimetic 30 milligram tablets once daily. In 2022, the patient lost right shoulder swelling after consultation for orthopedic surgeon. She was asked to do MRI shoulder and repeat the investigations again. This is the MRI shoulder, as we can see here. It shows its consile lesion at the distal end of the right clavicle. It is almost about 5 centimeters in diameter. This is another photo of the brown tumor. The features of the forearm is 3.4, but with no osteoporosis in the spine or the left femur. Follow-up impact hormone was 1,800 picogram per milliliter, and the serum corrected calcium was 8.2 milligram per deciliter, which is in the lower limit of normal, and the serum phosphorus is 30 which is sufficient. At that time, the patient was advised to increase the dose of 6 we did for her ultrasound thyroid. As we can see here, this, the right loop, and this is the left loop. It showed no CT scan was done for the patient. It shows multiple expansile lesion or tumor that was present in multiple ribs of the patient and was present in the vertebrae. And also this is a brown tumor that we have seen in the MRI of the patient scan. To assess the parathyroid by the 4D CT, it showed small ovoid lesion that was more hypoechoic than the thyroid gland. It was present in posterior to the upper pole of the left thyroid gland. It was suggestive of left superior parathyroid adenoma. As regards the past-medical history, she is a hypertensive patient for the last 8 years in the stage renal disease, doesn't have diabetes with no history of any fractures. Drug history, she is on antihypertensive medications and on sinacalcet and calcium acetate. The post-family history, she had a post-family history of end-stage renal disease of her mother and her sister. On examination, it was almost unremarkable, no palpable masses by neck examination. The vital signs were normal. She had a displaced cardiac apex, and the shunt of the left upper leg was injured on the hemodialysis. To summarize our patient, she is a 37 years female, end-stage renal disease, hypertensive patient, has a multiple brown tumors. She has osteoporosis in left forearm. She had serum corrected calcium on the lower limit of normal. Phosphorus was on the upper limit of normal. The intact hormone was shooting, and the 25-hydroxyvitamin D was 31 nanogram per milliliter. She is on sinacalcet and calcium acetate. The 4D CT showed left superior parathyroid adenoma. of the parathyroid surgery. My questions are, is the patient indicated for surgery at this stage? And if we consider increasing the cinacalcet, especially our patient in a low dose of cinacalcet, would that control the condition to a degree that surgery wouldn't be needed despite of the presence of multiple brown tumors and the presence of parathyroid adenoma? And thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm really happy and pleased to be among you and in the prestigious conference. And special thanks to all the great colleagues and for inviting me for the hot topic, which is interdisciplinary. Actually, it's a real MDT, multidisciplinary team. We have the endocrinologists, the nephrologists, and endocrine surgeons, and the forefront that was put by our colleague, Professor Dr. Hanan, and how we need to deal with. So, pardon me if there will be a lot of the pathophysiology and molecular biology, but this is endocrinology, more than nephrology. But I try to cut this too much to the lowest and focus on the clinical aspect. First of all, we have to know that we have changed from the previous terminology of renal osteodystrophy to the current terminology of CKD-MPD or chronic kidney disease, metabolic bone disease. And this is an important issue because it's a total different scenario. And this changing perspective because of the blood vessels, which leads to what was previously known as calciphylaxis and currently known as calcific uremic arteriolopathy. Just alluding to what Dr. Hanan shown us, actually it's not needed to do an MR to diagnose a tumor, a brown tumor. This is a patient, is a real patient of ours that was a CKD patient, end stage, on dialysis for 12 years, and as you can see, she had got a couple of brown tumors in her jaw, and the next to the left is such a picture of her lower limb showing the calcification in the tortuous blood vessel. This lady was 25 years old, but she was on dialysis for 10 years. That's why she had got these horrible calcification and these brown tumor. This is a very, very clinical scenario that we see everywhere. And this is another patient that just presented by dry gangrene on her foot, or if you'd like to say a calcific uremic aorta and the iliac vessels and down to the beaded vessels and the anterior and posterior tibial, and the patient is really secondary to the tertiary. This calcific uremic arteriolopathy has got a fatal outcome with a mortality of about 60% in the patients, mainly related to sepsis that complicates these gangrenous patches and these very poor healing wounds due to the precipitation of the calcium of the blood vessels of those patients. So let's have a glimpse on the pathophysiology of this situation. We have to differentiate from the early to the late CKD to understand what is the difference between secondary and tertiary hyperparathyroidism. First, in the early CKD, the main issue is that the retention of phosphate due to the poor excretion by the kidney with the normal intake of phosphate in the diet leads to increase in the phosphaturic hormone, which is the FGF23. And the FGF23 starts to act on the parathyroid, and it acts on the parathyroid in two ways. First, it acts by decreasing, then lately it increases through the soluble slow receptor. And early on, this phosphaturic hormone can normalize the serum phosphate again, and the patient is more or less in a quiescent stage, and his or her bone mirror findings in the blood are okay, her bone situation is more or less good, and her cardiovascular or his cardiovascular system is intact. At this point, مستحيل ان انا اقول الحته دي in plain Arabic language because we consider this is a fatal bad maneuver that whenever a patient with a serum creatinine of 1.5, 1.6, most of the internists and the GP up till now they thought that the treatment is calciumet 1 alpha. Please, you are killing the patient. والله ده قتل خطأ بقى، مش هنقول قتل عمد يعني، بس لا يجوز ان حد يدي عيان early CKD 1 alpha and calcium without checking the calcium, the phosphorus, the PTH, the vitamin D زي ما الدكتوره هناء وريتنا، ولو كان ال FGF23 available around we should do as well. Giving those زي ما هنشوف في اخر presentation ان شاء الله، giving those drugs كده anonymously or without having the baseline, you are doing much more harm. لأن حضرتك ممكن تكون by yourself inducing بالفيتامين دي اللي أنت بتديه للعيان more hyperphosphatemia، بالكالسيوم اللي بتديه للعيان hypercalcemia أو borderline hypercalcemia that is not needed. والنتيجة you increase the calcium phosphorus product and you let the patient go into what we have seen earlier. On the other hand, with advanced CKD, it's more disastrous. The FGF is shooting, the serum closure is decreasing, the PTH is moving from secondary to tertiary, from زي ما شفنا في الصورة الأدينوما اللي اتشافت دي مش simple أدينوما بتاع primary hyperpara، دي simply خالص أدينوما that occurs in the tertiary features. And this derange all the secondary. Calcium, phosphorus, FGF, and vitamin D, all of them will be deranged. The simple algorithm, just to show you that whenever you have a kidney disease, the phosphate excretion decreases, these lead to phosphate retention. FGF23 is the very first player اللي هيحاول يعمل hyperphosphatemia علشان ينورماليز الفوسفيت، لكن لما بيعمل كده it will decrease the 125 dehydroxylase. Well, 1 alpha hydroxylase will also be decreased by the poor conversion in the kidney, and this will shift toward the 24 hydroxylase, as you know better than me, and this will lead to deficient active vitamin D and hence parathyroidism. Just to mention, secondary hyperparathyroidism is not limited to CKD. It can be seen in a lot of other situations, as you can see here. But there is a main issue with a CKD caused secondary hyperparathyroidism. You would almost always find a high to high normal phosphorus level. On the contrary to other causes of secondary hyperparathyroidism, which a little bit might mimic the primary hyperpara in having low phosphorus level. And this is the evolution of the secondary and tertiary hyperparathyroidism from a normal parathyroid gland to diffuse enlargement of the gland to early nodularity to purely nodular gland, and then you might have a single nodule, and moving from a polyclonal to monoclonal proliferation, and moving from a secondary to tertiary phenotype of hyperparathyroidism. And of course, there are many contributing factors, not only the low vitamin D level. Our situation does disaster to the bone and to the cardiovascular system. Having the renal osteodystrophy and female sex and postmenopausal definitely, accelerated aging, being diabetic, if you have chronic metabolic acidosis, which we have in all our patients, and decreases the osteoclastic and osteoclastic turnover and activity, and definitely the immunosuppression and the steroids that we are giving to most of our patients, even when they are transplanted. And along the stages of CKD from stage 1, when you have a normal GFR but still have abnormal kidney function, down to stage 5, you have a lot of layers. Starts by what we know as the cytokine inflammatory milieu in the chronic kidney disease by increasing TGF-beta, uremic toxin, and inflammatory cytokine acting on sclerostin, leading to increase in the sclerostin, and then the downhill pathway of the Wnt DKK1 versus the sclerostin, LRB5 and LRB6, and the pathways between those molecular pathways, and I'm not going to go into details, but the end result will be an imbalance between osteoclastic, and osteocytic activity in the bone, leading to defective mineralization, osteoporosis, osteomalacia, maybe increased turnover, leading to the osteoitis fibrosa cystica, or on the late stages, leading to the adynamic bone disease, or you might have a mixed phenotype of these. So these actually molecules going to the ferritin and the osteoporphyrin and all other types are really important, and they might have some prognostic factors as well. And this is just how it continues through the cyclic AMP and the protein kinase A and protein kinase C, doing the malicious end result on the bone as well. And as you can see, chronic kidney disease in the middle, and you would have around the FGF and clotho legend together, the vitamin D, the hypocalcemia, the hyperparathyroidism, the hypogonadism, which is, as you know, is a somatic type, the increase of oxalate with the retention, heparin treatment, which causes again bone disease, as you all know, and amyloid deposition with the patient on long-term dialysis, specifically the beta-2 microglobulin, aluminium, which is used to be incriminated in adynamic bone disease, and we don't have aluminium toxicity from water treatment units nowadays anymore, and we don't even use aluminium binding phosphate binders except for a very short rescue therapy, and this is another important issue. You only are allowed to use aluminium binders for hyperphosphatemia in a CKD patient for a couple of weeks in a year time, not more than this, or else you would end over by adynamic bone disease because the kidney wouldn't be able to excrete the aluminium nor the dialysis even. Again, the wine signaling, the malnutrition, the activine, the acidosis, the steroid treatment, all these together leads to the different type of bone disease. And of course, as we'll see, Dr. Hanan mentioned that she measured the intact PTH 184. Is it the right thing to do? Can we do better? How to do it? How big the difference? And this is likely a research that we are undertaking nowadays with the endocrinology unit to try to find out what to be done best in our group of patients. Again, this all plays into the blood vessel, and this is the major issue. The patient wouldn't die from the hyperparathyroidism, nor from the dialysis, even not from a bone fracture, but he would die from calcification of the blood vessel, from ossification of the blood vessel, if you would say, from calcification of the valves, from severe calcific uremic arteriolopathy, as we have seen earlier. Going to the bone, and I'm not going to focus a lot, but these are the main types that we can have in a patient with CKD or end-stage renal disease, along with his renal dystrophy. Osteoitis fibrosa cystica is essentially with a hyperparathyroid state, mixed disease association between two, hyperdynamic and adynamic, and osteomalacia, as you know, is an accumulation of non-mineralized osteoid matrix, where aplastic or adynamic bone disease is reduction of osteoid secretion, which can occur from aluminium toxicity or very low parathyroid hormone. Should we do a bone biopsy? We will see now that we are shifting toward non-invasive tools, although bone biopsy is still there, especially in our population. You can use the TREP5B, and this is a good marker for bone resorption, where you have the B1 and B for bone formation. On the other hand, by radiology, dual energy absorption, the DEXA scan, as you know, and the high resolution peripheral quantity as well. There's the reference point indentation that you can use. And here are some explanations to the diagnostic accuracy of non-invasive bone turnover in renal osteodystrophy, and you can come up with the result both in the exploration set and in the validation set, that you can have a good high cutoff value that point to what is collectively can tell the situation without doing a bone biopsy. This is a very, very important slide. This is the main differentiation between the primary, the secondary, and the tertiary hyperparathyroidism as regards the main three players, the calcium, the phosphorus, and the intact BTH. And please note that in secondary hyperparathyroidism, within a patient with renal disease, you would have a phosphate higher than normal. In other causes of secondary hyperparathyroidism, it might be lower, like in primary hyperparathyroidism. In tertiary, all of them are going crazy. Calcium is high, phosphorus is high, and BTH is very high, as we've seen, 180, 80, 100, and so on. The bottom of the slide is the evolution of the detection of parathormone by the first, second, and third generation kits in the lab. And the third generation is the intact parathormone, which is usually used as C-terminus, then the N-terminus, or what we know as N-terminal parathormone, which is not the 184, but it's rather the 1284. This is the second generation, whereas the third generation is using a highly specific detection antibody at the level of 1,4, and the capture antibody is the same C-terminus as the three tests altogether. I don't think that we yet are lucky to have the third generation here in Egypt, but it is digging its way and it is the standard nowadays. And as you can see over the years, it becomes to, in 2017, that the bone biopsy has been very limited to understand the knowledge of the bone disease if you don't have any clue by the other tests. This is our KDIGO criteria, and this is the same, the pictures of what you can have, whether you have a bone, a low turnover, or a high turnover, or other bone disease, or a mixed type. And if we finally look at the points of management, this is the baseline, and we have in our KDIGO criteria how frequent you should monitor the calcium, the phosphorus, the BTH, and the vitamin D in each and every stage of CKD. I didn't bother to get it to you, but this is how you should monitor the calcium, the BTH, and the phosphorus, and along the different ranges, you have to take different level of action, and this is the most important slide in this presentation. Please photo this, print it, put it on your desk, and use it for every and each patient with CKD and ED. It's simply the answer for what you should do if the patient has a hyperphosphatemia and a hypocalcemia and hyperparathyroid, or a hyperphosphatemia and a hypercalcemia and hyperparathyroid. It is the main armamentarium using the calcium-containing phosphate binder, the non-calcium containing phosphate binders, the vitamin D, which will raise the phosphate and the calcium, or the Zinacalcet, which will decrease the phosphate and the calcium, and you can just monitor the hours, what to do in each phase and in each stage, and you wouldn't miss if you go by this guidance. I'm not going to elaborate because the time will not be enough. Then etacalcetide is the next generation of Zinacalcet, which we are not using in Egypt, but it's being used abroad. Just an IV form that does not cause the GI terrible side effect of the Zinacalcet, and can be given to the dialysis patient on the day of the dialysis, on the end of the session, and that's it. It's much more effective, as you can see in the, it's much more effective in the, in managing the patient. Can I please? Yes. Just 1 more minute. Okay. So it's much more effective if you can see down there that the people on calcitide have got much lower level of PTH as opposed to those who remained on calcite. The other thing is this is the flow chart. What you do when you have a parathormone twice normal, and we aim for a parathormone of twice normal at least. Previously, we said that we have to have 2 to 9, and nowadays the KDIGO and the International Society of Nephrology recognize that it is the trend of the parathormone rather than the absolute value. So don't allow to get greater and higher each and every time you test for, even if it is within the 2 to 9 range. You have to stabilize at 2, 3, whatever, double folds. Measure the group-specific alkaline phosphatase and the parathormone, and according you would go forward whether you would do a treatment, whether you would do a bone biopsy, or you would do a parathyroidectomy. Lastly, the calcific retinopathy that we mentioned earlier, unfortunately, is very poorly treated situation. Nothing is beneficial. Even the sodium thiosulfate intralesional or intravenous does not get enough result, and most of the people die out of infections. There is a hydroxyapatite molecule, which is the SNF4-2, that target this HAP to try to prevent the internal calcification of the blood vessel, which might revert the calciphylaxis. Thanks for your attention.
Thank you very much, Dr. Ahmad, for this excellent presentation. I think both internists and surgeons will be having many questions for you, inshallah, at the end of this session. But we, as Dr. Samir said, we have to postpone the questions at the end of the session. And now I have the opportunity and the luck to